Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathin Berg.
So when was the last time you remember discussing a colonoscopy or colon cancer or anything of the like? Are polyps in your colon dangerous? Is it something that can be removed? Can cancer be prevented? That's what we're going to be talking about today. This evening's program is underwritten by University Medical Center, and we also want to thank the El Paso County Medical Society for bringing this program to you for over 29 years. I'm Kathin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Thanks again for joining us. We're going to be talking about colon cancer and colon cancer awareness, just awareness of the digestive tract. And we have one veteran here with us. And Dr. Patel and I were discussing, he said, wow, I remember when we were recording the show back in the UTEP days, which means that you're one of the very first doctors we had on this program. So welcome back. It's nice to see you again. This is Dr. Vinay Patel, who is a gastroenterologist, and he's also the medical director of the Endoscopy Center. And we have two newbies, but I'll tell you what, you guys bring the energy in the room. I love it. Grace was here early and introduced herself as Grace. So hi, Grace, how are you? Grace is Dr. Grace Hopp, and she's also a gastroenterologist. And then we have Dr. Jesus Guzman, who's a gastroenterologist. So that being said, what I'd like to do is start off, and Dr. Patel, you know how this works. Gastroenterologist, sure, what in the world does that mean to people who don't know?
Most of you probably will see us during your lifetime. We deal with diseases of the gastrointestinal tract, which is anything between the mouth and the rear end. And that also includes the liver, the pancreas, the gallbladder. So if you have abdominal pain or sometimes chest pain, which is not cardiac, or if you have diarrhea or constipation or bleeding, any kind of ailment.
We get to talk about all that fun stuff.
Correct, absolutely. And sometimes just weight loss. Yeah. So you certainly would see us for any of those. And if you're anemic, if you're losing blood, that's another common reason. Or if you're vomiting blood, that would be another reason why people would come to see us. Okay. But one of the services we do provide is screening for colorectal cancer, which has certainly been a very hot topic in the last few years because of the significant increase in incidence and death rates in younger patients under the age of 50.
Exactly, and that's something I'd like to really get into, and I don't know if we know all the answers of the whys, but we'll talk about some people that have been affected that a lot of people know as household names. Dr. Hopp, I didn't prep you for this. Sorry about that, guys. So what we do now is we talk a little bit about you before we start the show.
Perfect.
But you talked a little bit too that you grew up in Chicago.
Yes.
And did a lot of your training in San Antonio. Talk about why you went into gastroenterology and what got you here.
Well, I grew up on the west side of Chicago, west suburb, and I've just been working my way down since. So I went to med school in Kansas City, and I got to do a rotation in gastroenterology. And when you find what you love, there's just no way to put words to it. It just captivated me. I went home and I read about it, and I was the first person in the workroom every day. I was just so excited to go to work. And I was always excited, but this was just so new. You got to talk to patients, you got to actually fix people, fix a bleed, fix diarrhea. So it's very satisfying. And then you also get to do procedures. So we get to use our hands and help diagnose and kind of fix all at the same time. So you get
and
to
these
do
are
a lot.
common everyday problems. Like
Absolutely.
everybody has had something
Reflux,
that Dr. Patel,
diarrhea.
exactly.
Yes.
We actually did a
We see
promo
it all.
about that once. It's like, it's not stuff you talk about with your friends, but you can talk about it here. Kind of love everything about that.
You'll be surprised how many people talk about it at the dinner table now.
Well, because they know that you're that guy. If they didn't know you were that guy, you know. So Jesus Guzman, Dr. Guzman, how about you? Are you in El Paso and did you come from us from somewhere else?
No, I'm born and raised in El Paso. Yes. I've actually done all my training in El Paso. I did my medical school here, my residency, and my fellowship. As far as the reason I went into gastroenterology is similar to Dr. Hopp says, like, it's something that you get to work with your hands and you get to follow your patients through and through. And I knew it was a big need in the community. Like in our community in El Paso, there's not a lot of gastroenterologists. And I knew that at the end of the day, I was going to end up being here. My wife told me when I was going to medical school that I could go wherever I want, as long as it's El Paso.
Oh, I love that. I like your wife. Good job. So let's get into the meat of why we're here. Let's talk about the colon. Because, and I know usually, we would have a model. Next time you have to bring a model because that's always fun. Because we've got the small intestine, the large intestine, we've got the colon, we've got the rectum, all of that. So if you can describe, since we're talking about colon cancer, that's more of a thing than like you don't hear small intestine cancer, you don't hear large intestine cancer. Explain what the colon cancer situation is, where the colon is, why it's so dangerous. You know the thing.
Colorectal cancer has always been an age-related disease, meaning I remember in 1995 when I started my practice, patients used to come in, and the younger patients, we never used to worry about colorectal cancer. We always used to think they had some benign disorder called irritable bowel syndrome as a cause, or hemorrhoids or something. But as time has gone on, the statistics have changed, and the rise of colorectal cancer in young persons under the age of 50 is alarming. I mean, you're seeing an increase of about 2% a year in incidence of colorectal cancer.
Oh my goodness, 2% per year.
I mean, just to put things in perspective, for somebody who was born in 1999, has a 4 times the risk of developing colorectal cancer compared to somebody who was born in 1950.
So here's the obvious question that comes.
4 times rectal cancer if you're born in 1999 compared to 1950. So that's a huge increase.
The big question is why? Do we know why? I mean, I know there's a lot of educated guesses is the wrong word,
Correct.
but educated guesses.
Yes.
So what are some of those that you, in your symposiums and your conferences, talk about?
Well, there's a lot of mechanisms. Environmental factors, for example, it's what we're ingesting. Our diet has changed over the last few decades. We have highly processed foods coming into our diet. We have microplastics coming into our diet. And microplastics is big. The problem is that we're still right at the beginning stages of learning about what their risks are. I mean, we've all heard about plastic bottles. Don't drink from plastic bottles, especially if they've been out in the sun, because some of the ingredients they add to the plastics to make them more flexible or hard have microplastics in them. BHP is one of the products you may have heard about. And so as a result, I mean, we just don't know their impact, but we do know that it does affect. I mean, the use of antibiotics in young children is extremely high, and that obviously alters our biomes, and that certainly will affect our risk. Food additives like colors, I mean, those things are adding to the risk as well. So it's certainly, I mean, there's so many factors, and we're just beginning to learn, and I'm sure that others will have other factors they've heard about or read about, which will come up as the discussion goes on. But at the end of the day, the facts are the facts, and what we're seeing now is that what used to be a disease of the elderly is now also affecting the young people.
And I'm going to talk about, we talked about in the beginning of the program when this started, for people who have been around for a while or of actually a little bit younger than my generation, but James Vanderbeek, who just passed away, and he was in his 40s, so he was diagnosed quite early. Also Chadwick Boseman, you talked about that right when we walked in from Black Panther, he was in his 30s. So going into the idea, it's not the old person's disease anymore. And then Catherine O'Hare, yes, she was in her 70s, and she's someone who was a comedian. A lot of people know her from Schitt's Creek and a lot of other shows as well. She was in
Home Alone.
Home Alone, thank you very much. She was the mom in Home Alone.
Yeah.
But yeah, it is all over the place now. And this is something too that Dr. Hopp, I'm gonna go to you and just say, colon, when you're talking about a colonoscopy, what is going on in the colonoscopy, if you don't mind kind of walking us through it, and why it can prevent this, like the polyp removal, et cetera, et cetera. So
Great question.
Take that away.
First and foremost, the patients do a prep. One of the most common misconceptions is that the prep is terrible. It's very tolerable. So they clean out their intestine the night before, the morning of the procedure, and then they come and see us.
And describe that. I mean, let's talk layman's terms. Literally, you have diarrhea for
it's not
12,
pleasant.
15 hours. It's not pleasant, but it's not like
but
it's
you can
terrible.
do it.
So that's the prep.
Yes.
Okay.
You drink a gallon of fluid that cleans out your bowel. You're going to the bathroom on and off all night. And then you come see our lovely faces in the morning. Our anesthesia providers put you to sleep for the procedure. You lay on your side, and we use a long, flexible scope that's about the size of my index finger. It has a camera and a light on the end of it. We insert it through the rectum, and then we're able to look at the whole large intestine, which is inside our body like an upside-down horseshoe. And we go to the very end where the large intestine meets the small intestine. And then on the way back, we're looking for what we call polyps, which are like growths of abnormal tissue that arise on the lining of the intestine. The large intestine that we can remove during the procedure. So those can be precancerous, they cannot be, but we use what's called a snare, which is just a little circle that goes around the tissue, and we just scrape it right off. We send it to our friendly pathologist who tells us what it is. And then we're able to tell you kind of when you should come back to see us for your next colonoscopy based on what risk profile those polyps have. So we're able to prevent you from having colon cancer if we can kind of get all of those removed before they become a problem.
So I'm going to talk about you and me. So literally last year, I went and had my colonoscopy. Dr. Patel was very nice, held my hand for a second, went in. But I did have a polyp. And it was like, oh my gosh, I have a polyp. So I now go in every 5 years. If there's no polyp, you go in every 10 years. But is that something that's changing because of the incident rate with colon cancer? I don't know if that is something that's been talked about yet, or if the screening is changing. Once you've had your colonoscopy, if there's no findings, do you still wait 10 years at this point? Are you waiting for less?
I think for now, anyway, most patients who have a clean colonoscopy and they have no other risk factors, then I think every 7 to 10 years would be a reasonable interval for most of them. Now, in the younger population, it's hard to know because we don't have long-term studies to show, because they obviously have a different profile. And so it's possible that we may have to survey them at a shorter interval and maybe even screen them at a shorter interval. I think those are things which are still being investigated. But for now, I think we're still applying the same principles to them as well. But that may change as more information becomes available.
Okay, excellent. Dr. Guzman, now it's your turn. See, this is that show we kind of do. We do ping pong back and forth. So let's take it now from where Dr. Hopp left off. We have the colonoscopy. Let's say there was a polyp, and now the friendly neighborhood, what did you call it? Pathologist has it. So let's say that polyp comes back and it is malignant. Because benign means there's no problem. It was just a polyp that just grew, but now we think, okay, there's a little bit of cancer there. Where do you go from there? And I know it's different with every person, but for the most part.
So by definition, cancer will be when there's submucosal invasion. And
say it slowly. Submucosal invasion?
Yes.
Okay.
So that is what differentiates cancer, because you can have dysplasias that they'll say carcinoma in situ in a polyp, which by definition is technically not a cancer. Okay, but
so in situ just means that polyp and only that polyp had it. It has not
crossed into the submucosa. The reason being that that's important is because we have lymphatics, we have blood vessels in the submucosal area, and that's how cancers can spread. So the idea is that when we can remove something before it invades, then that means you're cancer-free, right? Like if there's a carcinoma in situ in those areas. And sometimes we get them in certain polyps, like in the pedunculated polyps. They have longer stalks, can go ahead and remove them. Now, if somebody actually develops cancer, right, colorectal cancer, it depends on how deep and how spread out it is.
Right.
Now, the importance of it is that the earlier we detect something, if we just detect it at an early stage, it has a much better survival rate at 5 years than if it was already too late, like as in it's already spread and gone to other organs. So if, for example, in 5 years, your survival rate will be at 90% if it's detected at an early stage.
So are you able to describe here what the stages would be? So say there was, and let's just go back to, there's just one polyp that was removed. That one was malignant. What do? Do you go back in and try to remove more of that area, or do you just know at that point?
Usually if it is in the mucosa, that's where we work.
Okay.
We can do EMRs, polypectomies. Now, it's a mucosal, submucosal resection. Mucosal resection is we lift the polyp off and separate it from the layers of the colon, and we're able to resect the polyp.
Okay.
Now, the thing, we can go in a little deeper. Now, if it has spread beyond that, then our role is more of the diagnostic and obtaining tissues. At that point, we work with our oncologist and our colorectal surgeons. If it is still localized to the colon, they can remove that section of the colon. And then depending if there's lymphatic spread or not, then there's a determination by the hem-oncologist, which is the cancer doctor, whether they're gonna get therapy or not. Sometimes they get neoadjunctive chemotherapy before they get before they start or afterwards. And it is the decision that is made by the oncologist once they get the pathology, they see what type of cancer it is, how aggressive it is, if there's any lymphatic spread. But that's the importance of catching things early.
Correct. Yeah, and that's a perfect transition too for Dr. Patel now. So as a gastroenterologist, now there is cancer specifically, so now it's time to bring on the oncologist. So in that team working, I remember cancer boards or tumor boards back in the day. I don't know if that's still a thing.
It's still a thing.
So how does the conversation then have, this is patient A, has a polyp removed, it is malignant, now the oncologist comes in. How does that relationship start? What's the conversation, et cetera?
Okay. So if you have a malignant polyp, like Dr. Guzman said, you determine whether it's localized to the mucosa or if it's spread beyond. Usually most of us, when we do remove a malignant polyp, we will try and tattoo that site.
Okay.
Because we're getting the patient ready for possible resection of the colon. And sometimes in early stage cancer, the surgeon's looking through the belly button from the outside. And they may not be, if it's a very early stage cancer, they will, from the outside, the colon looks completely normal.
Right.
And we need to make sure that they don't cut out the wrong part of the colon, right? Because my description of distance may be very different. Colon's like an accordion, right? You could be, on the way in, I could be at 60 centimeters, and on the way out, I'm at 30 centimeters. So the distances can vary tremendously. And so the idea of doing a tattoo is so that, I couldn't make a living being a tattooist, but because
all you need is a good Sharpie, get in there, and X marks the spot.
So we do that we do that, and then we actually sometimes we do preliminary staging as well while we're waiting to get the patient in to see a surgeon and the oncologist as well, because staging will determine if there's any spread beyond the colon, which is obvious, because that will then determine what exactly they will need. And so normally, let's say you had a malignant polyp, I've tattooed it, and there's some involvement of the lymphatic vessels under the microscope. So then I'll pick up the phone and I'll call a surgeon and I say, hey, first I'll talk to the patient, obviously, that they have no surprises there. But and then we'll talk to the surgeon, get them in to see a surgeon. And sometimes, depending on your concern whether they need an oncologist or not, I think you have to individualize. Some people, it's still very early stage. We wait for the surgeon to take out that segment of the colon, wait for the actual full pathology report and the surrounding lymph nodes, which have also been removed. And then the determination can be made whether you need to have an oncologist involved or not.
Okay.
Because that will then determine if they will need any chemotherapy or not. Okay. And there's so many different types of scans available now. We have CAT scans, we have PET scans, we have MRIs. And we're often reliant on the PET scans for when it comes to malignancies because it will detect any, quote, hotspots, which may be of interest to the surgeon and the oncologist as well.
And describe what PET stands for, because you've got the MRI, you've got the ultrasound, you've got the PET, and just for people again that this is not
it's positron emission technology, and what happens there is that they're given a substance which is then taken up by rapidly dividing cells, and it will appear as a hotspot in the intestines.
Nice. Dr. Hopp, you ready for this one?
Sure.
This is where it's silent symptoms. So this is one we prep for.
Perfect.
They're so cute. And I do this because it's fun, right? This is my homework. This is their homework. But we do this so we don't waste your time. So when we talk about silent symptoms, we were just finished talking about screening. So we don't know, we're just going to go in and be good people and have our screenings done. So silent symptoms, what are they? And I think sometimes a lot of those are dismissed, and maybe throw in some myths around there, etc. So time to talk about what you prepped for today.
Well, just like they both alluded to, colon cancer can grow, very slowly, and we can catch it at early stages. So a lot of patients, may be having very, very subtle symptoms and disregard them because they're so subtle. So things to look out for, like change in bowel habits, like persistent diarrhea or persistent constipation for more than 2 weeks, incomplete evacuation where you feel like you didn't release your entire bowel movement, or like pencil thin stools, like your stools all of a sudden become very, very skinny. That can all indicate that there may be a mass or a lesion growing in the colon that's changing how your stool is formed. Another symptom that's often not so silent, but rectal bleeding or blood in the stool is always alarming to people like us, and we always want to go take a look and make sure there's not a mass there. But that can look like bright red blood on the toilet paper in the toilet bowl, maroon stool, or even dark tarry stool kind of higher up in the colon on the right side. It can look, a little darker when the blood comes out. Dr. Patel alluded to this earlier, but if you're having unexplained weight loss, that can be a very subtle sign. Other things like unexplained fatigue can indicate that you're iron deficient, which Dr. Patel also alluded to. So a mass can be oozing blood very slowly, but so slowly that you're not seeing it. But you eventually lose enough iron that you become symptomatic. So very fatigued, weak, short of breath when you're walking around. Those are all very alarming signs and reasons for you to seek medical evaluation. There's more subtle things like bloating, nausea, vomiting, feeling of fullness that are very, very subtle. But if you are experiencing any of these, your friendly gastroenterologist would love to see you so that we can help you out.
I love this, your friendly neighborhood.
Yes, we
gastroenterologist.
are. We're all friendly.
I do love that. So I love what you're explaining, and along with colon cancer, which we're talking about that specifically tonight, but I want to talk about too, some of those symptoms could be irritable bowel syndrome. It could be a whole gamut of things. Yes. And that's where, again, it's so important to actually go see someone. So this is where the ping pong comes here now, right? So these are the silent symptoms. What are some other issues that a patient can have having these symptoms that it may not be colon cancer specifically? And we can talk about, again, irritable bowel. We have, diverticulosis, and a couple of other things too. So let's talk about some of those, because I think a lot of these are common issues and symptoms.
So the most common one that you're going to hear is irritable bowel syndrome. Okay, usually most of the time, what we end up doing is we end up working up looking for the more serious things that can be detrimental to life, right? Where like finding a malignancy, if you have something like inflammatory bowel disease, which is different from IBS. This one is essentially where your body's attacking your colon, thinking it's something foreign, and there's different forms. There's something like Crohn's disease, which involves the entire GI tract. Something like ulcerative colitis that involves the rectum and the entire large intestine. Now, this is treated differently than somebody that has IBS. These, something like inflammatory bowel disease, requires medications on the more severe forms, things called biologics, things to suppress your immune system, to keep your body from attacking those areas. And they present with subtle things like abdominal pain, diarrhea, rectal bleeding, also diverticulitis. A lot of the times we get patients that come in from the hospital that they had an episode of diverticulitis. They went in, they got a CT, and when it comes down to it is that it's a little pocket that got full of pus. And it's your anatomy. That's what it is. It's the way I describe it to most of my patients. It's like a pimple. It's like when a follicle gets clogged up and it develops an infection behind it. Okay. That's what a diverticulum is. It's an outpouching in your colon, and if a little piece of stool gets there in the right way, makes it stuck, and it'll cause it to get inflamed. Now,
and the treatment of that is you just remove that area and then you treat it with...
No. So that area is essentially nowadays we're actually even treating it conservatively without antibiotics, because most of the time they get better. But most of the time, if you end up going to the hospital, because that means it's a little bit more on the more severe side, they're going to give you some antibiotics to let it kind of cool down. But the idea is that we want to prevent the reoccurrence. People that have complications from like diverticulitis, we want to go in and make sure that it's not caused by a malignancy. Okay. But if it is a very recurrent issue, that's when we get our colorectal surgeons to help us out, and that's when we talk about trying to resect those areas, to remove that part. But that's later down the line, unless it's a very recurrent issue. But as I was mentioning, irritable bowel syndrome is something that has to do with the brain-gut connection.
The brain-gut connection. Yes. I want to expand on that. That's great.
Yes.
Okay.
And you know Dr. McCallum, he's a friend of the show.
Look at whose name's on here, because he was the last one who was on the show.
So he taught us so much about this, and he was a huge advocate for it. And IBS, it has to do, most of the time what ends up happening, somebody comes into the clinic and we do a full workup looking for these other things, inflammatory bowel disease, diverticulitis, and most of the times we come up with no answer. That means we're pursuing something we can't physically see, right? And that is the brain-gut connection. The way I like to explain it to patients is that when you feel nervous, where do you feel it?
We talked about the vagal nerve last time, if I remember that right, did we?
So there's a connection between the brain and the gut. And the thing is, our emotions can also be presented in our gut. And a lot of the times is that it is getting away from stressors, getting away from things that are causing you to have a physiological response. But now we have some treatments for it. Like if somebody there's 2 different forms, IBS with diarrhea, IBS with constipation, and we try and treat the symptoms. If it's somebody's causing constipation, we have medications that make you, less constipated. They'll make you go. If you're having diarrhea, we try some antibiotics with Xifaxan. And
once you have irritable bowel syndrome, do you have that for the rest of your life? You're just managing how you present? Is that kind of how that would be explained?
Most of the time, I've never seen a patient myself that who's come in is like, hey, I've been cured from my IBS. If anything, it's like, hey, my symptoms are controlled.
There you go.
And there's a couple of things that you'll see, especially now that patients are getting things at a younger age. Before, we had something called the Rome criteria. Essentially, we would say if somebody has abdominal pain, gets better with defecation, there's changes in the consistency of the bowel, there's changes in the frequency. Those are things that we're like, well, in a younger patient, we would say it's IBS. And nowadays, with everything changing, I feel like that's going to change.
I see. And again, you're beautiful because you're teeing up now, Dr. Patel here. So because there's a lot to diagnose, and I want to talk about diagnosing all these different issues. Colon cancer, we talked about that. That's a specific pathology diagnosis. So when you're talking about, I'm having issues, like I have diarrhea one day and then 2 weeks later I'm constipated for a month and then I have diarrhea. So somebody's coming to you and they're describing symptoms. What is the gamut of testing that you do? Because you were talking about a PET scan, you were talking about different, so how does one diagnose what they have?
I think you start with the basics. You get a good history and a good physical. And you obviously take into consideration the age of the individual, the duration of their symptoms, and if they have any hard findings. For example, have they lost weight associated with the symptoms? Are they anemic with those symptoms? Or if they've had a change in the color of their stools. Those things are things you can actually visualize, document, and go from there. You can certainly, I'm going to introduce a term called medical gaslighting, which is what which is what
I've heard this term.
Which is what Dr. Guzman was getting to.
I thought you were going to talk about the sewage workers, which we talked about before we started the show. Thank you for laughing, Grace. That was very kind.
We've been called a lot of things, but medical gaslighting basically is a term which has now come into focus for the younger patients, because essentially the young patients, in the past, like Dr. Guzman said, they would come in and we would say it's irritable bowel syndrome, okay? And we would manage them conservatively, and we would try and manage their symptoms as best as we could with the drugs we have available. And they've certainly exploded in the recent past, but you always get an idea of how not so good we are at treating these conditions based on the number of drugs available. So when you have 30 different options, you know that we're not very good, right?
Yeah.
So what's happened as a result of this medical gaslighting is that the younger patients who are developing colorectal cancer and being diagnosed, 3 out of 4 of them are at advanced stage. Because by the time we get to the actual test, which makes the diagnosis, their disease is so advanced. And that's why when you see all these movie stars who are getting their colorectal cancers at a young age, they're dying within 2 or 3 years. Because by the time they've been diagnosed,
they've been told somewhere along the way.
They've already had symptoms for a long time and they've been ignoring them themselves, or if they were to see physicians, and I'm not saying that physicians committed malpractice, it's just the nature of the disease. I mean, this disease is no longer a disease of the elderly. And so, but to go back to your question about how would I work a person up? So if somebody in their 20s comes in, I'll get their history, get their physical, and the history would include things like the duration, et cetera. And then depending on the severity of their symptoms, I think most of us will probably try and treat them conservatively with medications we have available, but we probably won't sit on them for too long. If I come back and you come back to see me in 12 weeks and you say, Doc, you know what, I'm not any better, then I think we will probably then talk about doing a procedure, probably a colonoscopy and maybe even an endoscopy, depending on where their symptoms allow us to go, if they have a lot of upper GI symptoms. And oftentimes they'll end up having both, along with some imaging studies. It could be an ultrasound, it could be a CAT scan, and possibly even some stool studies. There are certain stool studies which will allow us to differentiate between somebody who has an inflammatory process going on in their colon, such as fecal calprotectin, versus, or even doing fecal leukocytes, which will tell us if there's increased white cells. And you may even do some cultures and some ova and parasite studies, depending on if they've been traveling a lot. And so there's a whole gamut of tests you can run. And so I think what you order will very much depend on where the predominant symptoms are. But at some point, most patients with irritable bowel syndrome will end up getting a colonoscopy and or an endoscopy. Endoscopy would be from the mouth and above. And the reason I prefer to intervene earlier is because if they're normal, great, we can move on.
Exactly.
Most people can
But
live
you'll
with
know.
it. And you know what I found, having been in practice for so many years, once you tell a patient that the procedures were fine, all of a sudden the irritable bowel syndrome symptoms don't seem so bad. Meaning that stress, because nowadays with access to the internet, a lot of people will Google their symptoms and they'll get a list of conditions, and like Google will tell you, it'll start off with the worst before it goes down to
It's
at least
Dr.
a bad,
Google,
right?
yeah. My daughter's a Dr. Google
And so
searcher.
you'd be surprised. And there's this expectation, patients when they come to see us, that the only reason they're seeing a specialist is because they want this additional testing done, because their primary doctor could do everything else.
Right.
So why am I coming to see you if you're not going to rule out all of these really severe diseases? So all things said and done, there's so many, I think we're a lot better equipped today in terms of diagnosing. I mean, you could have deficiency in disaccharidases, which are enzymes which help you digest sugars. So now we have tests we're able to do that for as well. And we have medications. It's like having lactose intolerance. And you have lactate for that. And where we have sucrase now, which will help you digest other types of sugars as well. Now, as far as treatment goes for irritable bowel syndrome, certainly we'll try and modify their diet, their stressors, their medications, which might help with their anxiety. And my experience with IBS has been is that they'll go through episodes of flare-ups. So you'll see a patient now,
And there's
then
no
they'll
explanation
disappear
on their
for
part?
a few years. So life gets better for them, and suddenly they hit another stage in their life where they've had some stress or whatever, and they'll flare up, and suddenly they'll come back to you again.
I used to remember that was nervous stomach. Oh, he's got nervous stomach, and that was back in the 80s. And then it became IBS, and then it became like all these other things too. And then I felt like healthy gut was such a term that is being used right now. And Dr. Hopp, that's a transition to you now. So we're looking at changing the diet, right? But it's also, you were talking about biomes, you were talking about, I know there's a stool replacement. I learned about that when Dr. McCollum was here. It's like, oh, that's another thing. I don't even know if that really should be put in, but there's so many different ways of getting your gut healthy. Let's talk about some of the easy, non-invasive ways first. If someone would come to you and they've got issues, like, you know what, first, let's change your diet, let's start doing what? And that's what I'm asking you.
I think every gastroenterologist is going to recommend that you start a fiber supplement. So there's lots and lots and lots of different fiber supplements. They come in powders, they come in gummies. Yes, it is overwhelming. And there's different types of fiber. There's soluble fiber, there's insoluble fiber. So having a conversation, with your primary care doctor or with one of us can kind of help you navigate all of those choices. My personal favorite, and this is not an endorsement, but is Benefiber.
I'm writing it down.
It comes in a little green, like almost like a Crystal Light packet. You just put it in your water, stir it up, and drink it with an 8-ounce glass.
Okay.
So, that helps actually a lot of patients' stool consistency problems. So if they're having diarrhea, more fiber will add bulk to the stool. If they're having constipation, it can draw some water into the stool as well. And not not a single one of us gets enough fiber just by our diets. You can have the highest fiber diet and you're probably still not getting enough. So that helps a lot of people. If you're having a lot of bloating, some patients don't prefer fiber because it can cause some bloat as well. So it's just something to be aware of and kind of take the patient in as a whole. Probiotics have been a hot topic for a long time.
Exactly. I was just writing that down because you have the pro and then you have the pre. And then, pro was like the hot topic. And then, well, what about the pre's? And then they came in and somebody was getting jealous of the other. But talk about those because they are still something that's advertised quite a bit.
Yes.
Do you take the pro or the pre or do you take both?
Well, the Benefiber has a prebiotic in it.
Okay.
So you're getting both fiber and a prebiotic if that's something you're interested in.
Okay.
I will say like a lot of these probiotic type medications are not regulated. And so we often don't know how many parts per million of whatever bacteria you're actually ingesting. So one of my old mentors always told us, just take a spoonful of sauerkraut. That's going to give you just as much fermentation. It's a lot cheaper and we know actually what you're putting into your body. And it's going to promote the growth of good bacteria for you. So instead of spending all of that money on all of these fancy pills and running up your Amazon cart, just get a jar of sauerkraut. See how you do.
We didn't talk about this before the show because I'm a German. And so that's something
you love sauerkraut.
I do. I love sauerkraut, or my grandparents always had it. It's like kimchi in Korea.
Right.
You just have a little bit of it with your meal, and it was just part of the meal. And then later, my grandfather used to say, well, it's gesund. It's very healthy. It's very healthy. I'm like, yeah, it's sauerkraut.
He was onto something there.
Yeah. So I'm glad that you said that. So when you said sauerkraut, and people talk about yogurt too, like in the old days, you would drink yogurt or have some yogurt. Is that still a thing? People are like, well, there's too much sugar in the yogurt,
Yeah, I think, I'm not recommending people to go buy a jar of yogurt, but it definitely has benefits, like has a probiotic type effect. So if that's something that you want, you kind of have to take the patient in as a whole. If it's someone that doesn't have the means to go buying all of these fancy things, you have to work within their parameters. So it's definitely not like a first line thing that I say, like, go buy this type of yogurt.
Right.
No,
but to your point, it's about, just thinking
Yes.
when you're shopping and buying things.
Yes.
Speaking about thinking and human thinking and artificial thinking, because this is on what you have studied. So let's talk about what advanced equipment are you using to perform colonoscopies and diagnostics that incorporate the use of AI?
Yes.
So Dr. Guzman, that's you. And it's fascinating to me in the medical world. And we were talking about, a couple episodes ago, we were talking about the pit that has there was an episode on there where AI was used, good, bad, indifferent, et cetera. But talk about where are we in gastroenterology with AI? How is it being used? What do you see in the future, et cetera?
So right now, essentially, AI is being incorporated into our colonoscopies and capsules. Essentially, one of the biggest things when we do a colonoscopy is something called our ADR. All gastroenterologists are measured by certain standards, right? As far as an ADR is adenoma detection rate. And
say that slowly.
Adenoma detection rate.
Okay.
And this is a way of being able to see that we're doing good quality colonoscopies, being able to take our time to look for these polyps, because you can go in and come out quickly, but if you don't detect the polyps, then what's the purpose of the procedure? So especially with the use of AI, a lot of these polyps can be very subtle. They can be very flat, so a little bit harder to see. When we do our routine colonoscopies, the AI tool is a GI Genius, where essentially as we're going, it highlights potential polyps.
So pardon my ignorance on this, or my old ladiness on this. So is the AI incorporated within the camera? Does it read the images that the camera has taken?
It's
like,
the images. As it's looking at the images, it's like having a second pair of eyes.
Okay.
When we're doing a colonoscopy, we're looking at a screen and we're going through the colon and we identify polyps. So it's capturing the images on live, essentially, to be able to say, well, where there's an abnormality, and what it'll do, it'll highlight the area as we're going. And then sometimes it has a lot of, it's too sensitive. It'll catch a lot of things. But that's why we're there, where we go in, we say, well, no, that's not a polyp. It's just an irregular fold, and we keep going. But it alerts you to those things. So especially when you're having, let's say you've done a lot of procedures that day, some fatigue is getting in, it'll help you pick up all those things. And they've actually done studies where essentially they've seen that adenoma detection rate go up almost 15%, just from having it in the actual procedure. Our miss rate goes down as well. So the miss rate is the potential polyps that we could have missed. And it usually is about 25%. With the AI tools, essentially it drops down to 15%. And we at our institutions, we use the high quality scopes, high definition scopes. The better the endoscopy, you can do a colonoscopy, but it gives you a clearer picture, the better the scope it is, because we can see better. If you look back in the day, they were a little hazier, a little more grainy, not as much color. Nowadays, we can see very, 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 very clear pictures as we do the procedures.
Okay. I want to piggyback on missed rate and also something that we talked about a little bit earlier. So screenings, if there's no polyps and you start your screenings, could be 10 years, that's probably going to go less than that. If there is a polyp, 5 years. But I'd like to talk about the rate of growth of a polyp. And I know, again, it's different with everyone. But in my head, when I'm thinking there's no polyps, I'm just going to go back to the old days. You're 50 years old, you had your colonoscopy, no polyps, you don't have another one until you're 60. So what if there's one that's developing when you're 51 and you don't have a colonoscopy for 9 years? And in my head, I always thought, well, that type of cancer, that type of polyp, there must be really slow growing. But we're now looking at incidence rates a lot younger. And I don't know what question I'm trying to ask other than what have you seen over the last couple of decades in maybe growth rates of polyps? Is that something that the Academy's trying to change or whatever? And I'm just because you are the veteran, you and I are the old people on the board.
Well, thank you for making me know that I'm much older than these guys.
I'm a lot older than you.
But so, hopefully you're going to say I'm much wiser than these guys.
Yeah, exactly. But it makes me curious, right? Because we're really looking at, again, a lot of younger people being diagnosed, and it used to be a slow-growing cancer or polyps. Is that still the case, or is that being looked at more closely now?
Well, I think by and large, it is the case. The guidelines about the screening intervals came out not just from thin air. They came out from studies which they did. The National Polyp Study, which went on for decades. And I remember...
The National Polyp Study. Correct. Would you like to have been part of that? That'd be fun.
Well, we might have been. We just don't know about it. But at the time... So what happened is that people who very much early on, places like the Mayo Clinic, they're the first few clinics which realized that. I remember, because I did my residency there a long time ago, and people used to come from all over the country for their annual physicals, and they used to get a barium enema done as part of their workup, right? And they used to see these polyps, but didn't know what to do with them. But when they went back and saw them, and they studied them and said, oh, you know what? That's what turns into cancer. And that was one of the first indicators that polyps turn into cancer over time.
Give me an approximate year.
So the average interval between normal to developing a polyp to turning to cancer can be anywhere between, on average, 10 to 15 years. Okay. And that's what lends colon cancer prevention to colonoscopies, because we can intervene. Most people, when they talk about screening, for example, breast cancer, you're not detecting precancerous conditions. You're detecting cancer. Right. So even though it's calling cancer screening, you're actually looking for cancer. We actually go one step before that. We're actually trying to prevent colon cancer. And that's what, and I can only think of this as the only cancer where you actually prevent it from actually occurring by intervening sooner. So long answer to your question, 10 to 15 years. Now, the question and the answer I don't have is for the younger crowd, whether the interval is still 10 to 15 years. What I do tell patients now is that the 45 is the new 50, okay? Yes. And do not medical gaslight your symptoms, meaning I cannot tell you how many times I've seen young people come in with rectal bleeding and they say, it's my hemorrhoids.
That is something else I wanted to bring up. When you talked about that earlier, I think there's a confusion between the two, and it's like, well, I'm just dismissing this, so bring that up, yes.
So what I tell my patients is if you see the occasional blood once every few months or something, probably not much to worry about as long as there's no other symptoms associated. But if you're seeing it on a regular basis, don't self-diagnose yourself. Go see your primary doctor.
And with hemorrhoids, talk about this, and I know it's icky, but it's important to state the obvious. If it's a hemorrhoid, usually you can feel it. Like there's some soreness there, you can kind of feel it. I know there's a lot of silent symptoms too, I get that. But this is where you kind of not self-diagnose, but
again,
also try to think it through.
even with hemorrhoids, even if you feel hemorrhoids, and you can have both, okay? So if the bleeding is persistent and not going away, I would not just stay and say, what's a hemorrhoid? Go see a doctor and get yourself something done if necessary. At least a rectal exam or a physical exam. Right. Because most of us do not do rectal exams on ourselves. Actually, I do have some patients who will come in and say, I felt a nodule or whatever, but by and large, most of us would prefer not to. But having said that, I think it's very important to be aware of what your body is like. Now, some people will say, my gut was always like this, and that's who they are. I mean, they only go to the bathroom every 3 days. That's who they are, because normal can vary so much. Right. But there's certain things like bleeding or changing bowel habits. You know, one of the things about changing caliber of the stool, where the shape of the stool changes, it's a very non-specific symptom. But if it's something where you always had a certain style and suddenly it changes, then you may want to look into it further. Because in irritable bowel syndrome, you get all types of stools and shapes and sizes, and they vary all the time. So, but it's, again, to answer your question, 10 to 15 years is usually, and that's why, and when I say we find polyps, and I said 5 years, that's based upon the size of the polyp, the number of polyp, and the type of polyp. You may have to go every year, you might have to go every 2 years. And we also need to take into consideration other factors, which are family history. For example, you may have family members with colorectal cancer. You have one family member under the age of 65. You may have multiple family members of any age. In those patients, you may want to follow them every 3 years as opposed to every 5 years. So I think every person has to be individualized. But by and large, I think most people, if they get their colonoscopies done routinely, then at least we hope that we will capture most polyps and prevent them from getting colon cancer. And if they were to get colon cancer, we would detect them at a much earlier stage.
So I'm going to ask this because we're in El Paso. We have 10 minutes left, so I told you that would go fast. So start thinking about the stuff we haven't talked about yet that you want to talk about. And this is just a PSA for if someone is watching right now and they have no idea who to call to get a colonoscopy, what do they do? Dr. Hopp, would you like to? No, I'm kidding. Call Dr. Hopp. I thought you were married. But seriously, let's do that. Let's talk about who they call.
Most patients start with their primary care doctor, and their primary care doctor will put in a referral to gastroenterology. And then, I think all of us in the community do something called open access. So if you're a young, healthy patient that's either having symptoms or due for your first screening because you're 45 or older, if you're healthy, usually we look over your chart and we just bring you right to the endoscopy center for the procedure itself. If you're older or you have other comorbidities, you're on a blood thinner or other serious medications, a lot of times we'll meet in clinic first, and we'll kind of talk through the risks of the procedure, if your blood thinner needs to be stopped and who prescribes it to you and what the risks of that look like for you. And then we can schedule your procedure from there. But we don't want to prep you for your procedure, bring you in for your colonoscopy, and all of a sudden be like, oh no, you're still on your blood thinner, we can't do this. So we try to screen patients, not waste your time, not waste our time, and make sure that we have everything lined up. But usually, most cases, they start with their primary care doctor. And I am new to El Paso, but I found that a lot of these primary care doctors are trying to meet these metrics. And one of these metrics are, if you're 45 or older, you need some form of colon cancer screening, preferably a colonoscopy. And sometimes people are hesitant to get a colonoscopy. One of the most common misconceptions are, it's going to be painful or I'm embarrassed. And so a lot of those primary care doctors will say, well, why don't you go see them first and we'll see them in clinic and talk through all of that. I think sometimes just hearing about the colonoscopy, and a lot of times I'll bring my laptop in there and bring up Google Images so that you can see what the colonoscopy scope looks like and talk through kind of how that whole process looks like. Because I think, knowledge is power for us, for the patients. So if they understand very clearly what happens during the procedure and the lead up, then they feel a lot more comfortable moving forward. But yeah, anyone over the age of 45 So yes, not everyone, wants a colonoscopy. Despite
So we
our
talked
best
a little bit about
efforts.
Cologuard in the last show. I don't want to focus on it because I think gold standard absolutely is colonoscopy. But if
Right.
there's really a hesitancy, Dr. Guzman, you want to talk about Cologuard just because it's your turn?
Yeah.
Again, I will say proponent for sure, colonoscopy. But if there's some that just won't go there, what is Cologuard?
So first, I'd like to bring up two things that there's more than one method to get screened. Okay, we will push for the colonoscopy because, as Dr. Patel said, it's therapeutic and diagnostic. We can prevent. Now, is accessible to use the best. Okay, there's two types of studies that are commonly done, which is called the FIT test and the Cologuard.
And what does FIT test stand for?
The fecal immunochemical test.
Okay.
Okay, and this is essentially a test that you do yearly, and it detects microscopic traces of blood. And this is a good way of being able to detect cancers. But there can be other things that cause blood, like hemorrhoids, inflammation in the colon, and it can cause it to be positive. It has about a 72% detection rate, okay? But that's why you do it yearly. The Cologuard is better. You do it every 3 years, but that's because it can detect mutated DNA.
Okay.
Interestingly,
I didn't realize that.
It actually has a higher false positive rate than the FIT test. It'll be just because as we grow, we have more mutations and it can cause it to be a false positive. That one usually ranges about the 10-15% that it'll be a false positive, but it's really good at detecting things at about a 92% rate.
Wow. Okay.
So, but colonoscopy, at the end of the day, it's 95%. So
So this is a
detecting
patient
cancer.
who really, really tries to do things proactively. So I'm not going to have another colonoscopy for 5 years or 4 years now. Would it be wise for me to do Cologuard in 2 or 3 years? Just as a secondary. No. He's like, no, don't be paranoid.
No.
Okay.
So I, at least in my practice so far, like I've seen, it causes a lot of anxiety once you
I can see that.
You have a positive test, and then all of a sudden you're like, I had a colonoscopy last year. As long as it was a good quality colonoscopy, that you had a good bowel prep, there's no need for you to do a secondary test. Now, if you had polyps in the past, you need to get a colonoscopy.
Exactly. That's the only thing that's going to. All right. So we literally are at 5 minutes. So Dr. Patel, anything that we did not cover yet that you'd like to cover before we close up?
Well, what I would like to say is people ask me all the time, what's the best test? The test you get done is the best test, okay? And I'm a firm believer of that. Colonoscopy is the best test there is available, but for the patient, whichever test, as long as you're asymptomatic and you're getting your FIT test done every year, or you're getting a Cologuard every 3 years, or your colonoscopy every 10 years, that's the best test.
Okay. I like that answer. Okay. That was too quick. All right, Dr. Hopp, now you're on. You have a whole 3 minutes to cover. Go for it.
No, I think we covered everything.
I've got other stuff to fill in just in case, but I want to give everybody the opportunity just in case we miss something.
I appreciate it. Just highlighting that if you're 45 or older, please come see one of us so that we can make sure that you get the screening that is best for you and whatever test you can get done.
Okay. Guzman, same thing?
I would say, I would like to throw a plug for ourselves as far as...
yeah, absolutely. That's what it's for.
I would say, just to kind of emphasize back our ADR, which is on an average, you want to do 25% is a good ADR. And here at UMC...
say again what ADR is.
Adenoma detection rate.
Adenoma detection rate.
And this is a quality metric that we use to see the quality of the procedures. Okay, at UMC we have at 54%, which is almost double of what is expected. So we focus on quality, we focus on the care of the patient, and we have the best equipment to be able to provide that care. So.
Okay.
We're around for when the people need us.
I like it. I'm going to go back to something that is always in my mind during these gastroenterology shows. We're talking about red blood. And Dr. Hopp, you brought up black blood or something that looks kind of like tar.
Yes.
I want to discuss that a little bit in our whopping 3 minutes that we have left, because how do you know? And I guess too, some people, and I'm just going to say it like a kid, some people don't poop for 3 days. So if the blood's hanging out for 3 days, it probably isn't red when it comes out, right? For the most part. So I want to see, how can you detect blood when it doesn't look like red blood? And I, if you can be as specific as possible, because I know you said it's dark, it's tarry.
Right.
Any other way you can describe it for people to pay attention?
Yeah, so to start with, blood is usually like a laxative. It's very irritating to the intestine. So if you're someone that's constipated and you start bleeding for some reason, usually you see your stools pick up in frequency,
okay.
which can be kind of an alarm bell for you. Like, this is not normal for me, something's going on. The black tarry is actually from the body trying to digest the blood. And so a lot of times it will have a really kind of specific foul smell to it. So it'll smell very different than your normal bowel movements. Okay. Yes. And then we describe it like tar because a lot of times when people find themselves wiping, it's like actually sticky, like wet tar. So those are kind of some, alarm bell signals, when your body is bleeding slowly and digesting that blood.
Okay, that's super helpful.
Yeah, and that can happen when you have a lesion in the esophagus, the stomach, the small intestine, and the large intestine. So a lot of times we're doing an endoscopy, we're doing a colonoscopy, and then if we don't find anything, we're doing something called a capsule endoscopy, where we have you swallow a little pill camera that takes pictures.
Oh my gosh, I remember doing that years ago.
Yeah. And so we're looking for anything that may be bleeding slowly over time in your small intestine that we can't get to with our bigger cameras. That can, explain why you're having these dark tarry stools.
We need to do another program and talk about that capsule. I remember we did an entire program. It was fascinating. Yeah. And you have to bring images and show us how
and
it all
we'll bring in the little capsules.
Yes, I love it. Okay, we have to wrap up. Thank you so much. You guys have been, so we talked about the tango shows and the waltz. This was a great waltz of a show. You guys are wonderful. You work great together. And I learned a lot. So if you have not watched the show before, El Paso Physician, you can find this episode and many of the other episodes, really a good couple of years back, on 3 different platforms. You can go to kcostv.org. You can go to the El Paso County Medical Society's website, and that's a .com, but that's epcms.com. And then you can also go to YouTube at any time, anywhere in the world, all 3 of these anywhere in the world. You can just type in the El Paso Physician. Whatever the latest program is going to be the program that pops up. But you can also go back and learn about how shoulders are replaced. And I always talk about the fecal problems show, which is a couple of years back, but it actually had that in the title. And people are like, what? That's a thing? It's a thing. So thank you so much for watching. I want to say again, Dr. Vinay Patel, who has been with us, I'm going to say 27, 28 years, because back at UTEP, that's a lot. 31 years. 31. Okay, well, nice. And then we have Dr. Jesus Guzman and Dr. Grace Hopp. Thank you so much for being with us. I'm Kathin Berg, and this has been the El Paso Physician.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.